Welcome everyone to our video lecture series for EKG interpretation. This lecture will closely follow the book that we have on Amazon, and so once you listen to the lecture you can fill in the gaps and blanks in the book, making your own personalized EKG handbook. Basically, this is an interactive approach that we are offering so that you would better understand EKG and have it integrated in your long-term memory. Of note, in comparison to all the other books that are like 200, 300 pages to learn EKG, here we've developed a concise guide for EKG interpretation. So by the time you're done with this lecture, you will be feeling very comfortable with the interpretation of a normal EKG as well as highly encountered EKG abnormalities. So without further delay, let's proceed with our lecture.
In this video, I would like to discuss details on how to interpret an EKG and then go over some of the abnormal EKGs that you may encounter on the exam. So here we have the SA node where the impulse will be started, and that would correspond to the initiation of the P wave, and P wave is representing the depolarization of the atrium. From there on, the impulse will be transmitted to the AV node. So the time for the impulse to transmit from the sinoatrial node to the AV node corresponds to the PR interval. And the PR interval is between 0.12 seconds to 0.2 seconds. Once the impulse reaches the AV node, there is a delay of about 100 milliseconds, and that gives enough time for the ventricles to be filled before depolarization. From the AV node, the impulse will travel to the bundle of His. From there, it will go to the right and left bundle branches, and then from there on, it will go to the Purkinje fibers. So you should know the order. From the SA node, it goes to the AV node, bundle of His, right and left branches, and then finally we have the Purkinje fibers. So once the impulse is transmitted to the ventricles, it causes depolarization of the ventricles, and depolarization corresponds to the QRS, and the QRS interval, the duration is less than 0.12 seconds. And so the QRS interval corresponds to the depolarization of the ventricles. And then finally we have the T wave, which corresponds to the repolarization of the ventricles. So we had the depolarization of the atrium with the P wave, depolarization of the ventricles with the QRS, and then finally repolarization of the ventricles with the T wave. Now there is also a wave for repolarization of the atrium, but that overlaps with the QRS, and so you wouldn't be able to see that. Now, in addition to the facts I mentioned here, I would also like you to note that the speed of conduction is fastest in the Purkinje fibers, after that in the atria, ventricles, and the AV node. So the way I memorize it is park at ventricles avenue. So park corresponds to the Purkinje fibers, at goes for atrium, ventricles goes for ventricles itself, and then avenue goes for the AV node. So that's the order from which the speed of conduction is fastest to the slowest. And so AV node, it was slow because it gave time for the ventricles to be filled with blood. In addition, you should know that the SA node or sinoatrial node is the primary pacemaker. If anything happens to it and it's damaged, then the AV node would be the next pacemaker, and then after that it would be bundle of His, Purkinje, and ventricles that can act as pacemakers if there's something wrong with both the SA and the AV node. So here I have an EKG, and these are the steps through which you will have to interpret an EKG. So the first thing that you will have to know once you're interpreting an EKG is the rate of the heart rate. And there are two ways you can interpret that. So let me zoom in. So each of these boxes, the small ones that are shown here, are corresponding to 0.04 seconds. So therefore, one of these big boxes, which has 5 of them in there, correspond to 0.2 seconds. So if you want to measure the rate, what you can do is that measure how many beats are there in 6 seconds, and then multiply that number by 10 to give you what's the rate in 1 minute. So let's go back. So if each of these boxes correspond to 0.2 seconds, it means for 1 second, you will need 5 of these boxes. And so for 6 seconds, you will need 30 of these boxes. And if you count 30 of these boxes, you will notice that there is about 12 beats inside there. So 12 beats in 60 seconds times 10 is 120. So the rate for this patient is about 120. So if the rate is more than 100, then that is tachycardia, and if it's less than 60, then that would be bradycardia. Now, one easier way to calculate the rate is to find out how many boxes the next heartbeat is away from the first one. So if the first heartbeat is only 1 box away, then the rate would be 300 per minute. If it's 2 boxes away, then that would be 150. If it's 3 boxes away, that would be 100. And then continues going to 75 for 4 boxes and 60 for 5 boxes. So here we have the next beat in between about 1, 2, and 3. So we have about 150 and 100. So the heart rate for this patient is between 100 and 150. And from the first technique, we found out that it was 120. So both techniques will give you the same measurements. But I like the second one better because it's much faster. Now, if you have problem memorizing these numbers, all you will have to do is divide the number 300 by the number of boxes that you're away. So if you are 1 box away, then the rate is 300 divided by 1 is 300. If you're 2 boxes away, then 300 divided by 2 will give you 150. 3 boxes away would give you 100. 4 boxes away will give you 75, and then 5 boxes away will give you 60, would be the heart rate. Okay, now that we are done with the heart rate, next we will have to check the rhythm. And for the rhythm, you will have to see if every P wave is followed by a QRS. So here is an example of a P wave, and you can see after that we have a QRS. P wave, QRS, P wave, QRS. And then the rhythm is the same. So the space between every heartbeat remains constant. It's not being changed. So this patient has a regular rhythm. Now, if the P waves are not followed by QRS and the rhythm is not regular, then that would be an example of atrial fibrillation. So here you can see that we don't have a P wave before the QRS. Or here you can see there is no P wave before the next QRS, no P wave before the next QRS. And then you can see that in this patient, the rate is not regular. So you can see that for the first beats, it's a regular rhythm, but then after that, the distance increases, decreases, increases, and so on. So this is an example of atrial fibrillation where there is no P wave before QRS, and then also it's in tachycardic with an irregular rhythm. And then in these patients, you can obtain an echo to find out the underlying cause of atrial fibrillation. Usually there is a dilated atrium that causes atrial fibrillation, or there are mitral valve abnormalities which can again cause dilated atrium and lead to the atrial fibrillation. And then echo is also helpful to see if there is any thrombose that is formed inside the heart. Now, for the treatment of these patients, the goals are 1, to control the rate, and 2, to anticoagulate. So since there is blood stasis in atrial fibrillation, there is higher risk of coagulation and thrombose formation, and so you will have to anticoagulate these patients. And then for the rate, you would like it to be less than 110. And what you can use for that is, I use the mnemonic A, B, C, D. So A corresponds to atrial fibrillation, B goes for the first choice of the rate control that you can use for atrial fibrillation, which is a beta blocker. C corresponds to the calcium channel blocker. And then your final and least favorite choice is digoxin. So your first choice is beta blocker, then calcium channel blockers, and then digoxin is your last choice. So here I would like to tell you a story of a real patient that I had. This patient was actually being hypotensive, and so I was thinking about discontinuing the beta blocker or calcium channel blockers and start on digoxin because the blood pressure was running low. So I consulted the cardiologist and asked him of what he was thinking of replacing these medications with digoxin. And he was quite blunt with his response. He said, if you want to kill the patient, just go ahead and put it on digoxin. So he was maybe a little extreme in his response, but I would like you to know that the digoxin should be your last choice. So first you will have to try beta blockers and calcium channel blockers. And then for the anticoagulation, you can use warfarin or aspirin. So warfarin decreases the chance of stroke by about 70%, while aspirin decreases by 20%. Now, which one to use in your patient? For that, you will have to use something called CHADS-2 score. So we have the CHADS-2 score. So C corresponds to CHF, H for hypertension, age more than 75, D for diabetes, and then S2 corresponds for TIA or stroke. So if a patient has any one of these two, then that would be considered as 2 points. So if the add up of these points is 0 to 1, then you will have to give this patient aspirin. If the count is 2 or more, then you will have to give warfarin for that. Now back to the topic of the EKG interpretation. So we are done with the rhythm now. The next is the axis. So here we have the direction of the charges. With the normal axis, we have the QRS that is positive in lead 1 and lead 2. So here, let's go back to the actual EKG that we have. So you can see that our QRS is positive. It's upward in leads 1 and leads 2. So this is a normal axis for this patient. So let's go back here. So for normal axis, it's positive in lead 1 and lead 2. And so it corresponds to the minus 30 to 90 plus. So that would cover the normal axis. For left axis deviation, we have a positive 1 and a negative lead 2, which means that the direction of QRS is upward in lead 1 but downward in lead 2, and that corresponds to minus 30 degree to minus 90 degree, and that is the left axis deviation. And conditions that usually cause left axis deviation include, for instance, the left ventricular hypertrophy, right-sided myocardial infarction, or left bundle branch block. For the right axis deviation, we have a downward QRS in lead 1 and the upward QRS in the AVF. And so that corresponds to the positive 90 to positive 180 for the right axis deviation. And conditions that causes right axis deviation is, for instance, right heart hypertrophy, like for instance right ventricular hypertrophy, or left heart MI. So note that while the left bundle branch block can cause left axis deviation, right bundle branch block does not cause right axis deviation. So that's one difference between the right bundle branch block and left bundle branch block. And then finally, you have extreme right axis, which would be negative in lead 1 and negative in lead 2 as well, and that corresponds to minus 90 to 180. And so that would be right here. And it's really hard to interpret what's going on in these patients, and you do not need to worry about how to interpret those for your examination purposes. So back to the EKG that I have here. So this patient, as we discussed, has an upward QRS in both lead 1 and lead 2, and so that is a normal axis. So this patient so far was tachycardic, normal rhythm, normal axis. Next, you will have to check the intervals. For instance, the PR interval, make sure that it's less than 0.2. So normally PR interval is between 0.12 to 0.2 seconds. If it goes beyond 0.2 seconds, then you can suspect the heart block, like for instance first degree heart block. And if it's less than 0.12, then you can suspect the Wolff Parkinson White syndrome. So here I have an example of a Wolff Parkinson White syndrome for you. And in these patients, what happens is that there is an accessory pathway which will transmits the signal quicker, and so therefore the duration of the PR interval is shorter. So you can see from the end of the P wave till the beginning of the QRS, it's less than 0.12. So I discussed earlier, each of these boxes correspond to 0.04. For 0.12, we will need 3 of these boxes. And you can see that here maybe we have 2 boxes, but there's no way that the PR interval here is any higher than 0.12. And it's high yield for you to know the pattern of this EKG interval, so the accessory pathway will cause these changes that's shown by the arrow. Now, the medications that are contraindicated in these patients include the same medications that we were using for atrial fibrillation. So for atrial fibrillation, I said A, B, C, D. So for atrial fibrillation, we use beta blockers, calcium channel blockers, and digoxin, all of which decrease conduction through the AV node. Now the problem is that if you use these medication in a patient with Wolff-Parkinson, so you will decrease the conduction through AV node, and thus there would be increased conduction through the accessory pathway that is actually causing this abnormality. So it would worsen the condition in patients with Wolff-Parkinson syndrome. The medication that is recommended for these patients is the procainamide, and this is a sodium channel blocker that belongs to class 1A antiarrhythmetics, and then the mnemonic that I use for that is that pros can hunt Wolff. So pros goes for procainamide, and then Wolff goes for Wolff-Parkinson syndrome. So again, let's go back to the EKG that we have here. So if you're done with the intervals, next you will have to check for the P wave, look for the amplitude as well as the duration, and then that will tell you about the atrial enlargements. Then we have the QRS interval, and there are 2 points you will have to check for that. One is how wide it is, and that would tell you about the bundle branch block. And 2, you will have to look at the amplitude, and that tells you about the hypertrophy. So here I have an example of both the right and the left bundle branch block. So for the left bundle branch block, you have a QS complex in V1 and V2. So there is no R wave. We have just a QS interval in V1 and V2. And then in the V5 and V6, we do not see any Q wave. So QRS, so we don't see any Q wave in V5 and V6. So you can see it comes and then goes up right away. So there's no Q wave in either one of them. And then one other finding you may see in these patients is that they may develop the left axis deviation. So again, the findings: QS in V1 and V2, no Q wave in V5 and V6, and left axis deviation. In patients with right bundle branch block, on the other hand, present with R, S, R prime in V1 and V2. So here you can see you have an R and then R prime. R and R prime. Same in V2. We have R, R prime, R, R prime. Now the presentation of these waves is like rabbit ears, and that's the other term that is used to recognize the right bundle branch block. And then unlike the left bundle branch block, there is no axis deviation in patients with right bundle branch block. Now the memory aid that you can use for memorizing these changes is called William Marrow. So with the right bundle branch block, you will see M shape in V1 and V2. So here we had the M shape or rabbit ears in V1 and V2. With left bundle branch block, there is usually some notching in the V1 and V2. Here we don't usually see it. And so not necessarily all the time it applies to the left bundle branch block. However, it's a very good mnemonic for the right bundle branch block to use. Now back to the first EKG that I showed you. I mentioned that the QRS can tell you about how wide it is, and 2 about the amplitude. So how wide it is will tell you about the bundle branch block, which we just discussed, left versus right. Next, I would like to discuss the ventricular hypertrophy. So here we have the left versus the right ventricular hypertrophy. So for the left ventricular hypertrophy, we have an S wave in V1 and an R wave in V6. And the size of these S waves and the R wave is really huge. And so if you add them up in patients with left ventricular hypertrophy, it would be more than 35 millimeter. And then there's also a left axis deviation. With right ventricular hypertrophy, it's reverse, where you have an R wave in V1 and an S wave in V6, and then there would be a right axis deviation. And the size of the R wave in V1 and S wave in V5 or V6 is more than 10.5 millimeter. Now the memory aid that I have provided you to remember which waves to look for in S1 and V6 is SLR cameras. So I'm sure that you've all heard of the SLR cameras. So SLR, S goes for V1, and then R goes for V6. So we have an S wave in V1 and R wave in V6 of patients with left ventricular hypertrophy. So SLR. Again, S in V1, R in V6 of patients with left ventricular hypertrophy. back to the table. And then finally we have the ST and T wave interpretation. And T wave can tell you about different conditions, including the level of potassium in the serum. So in patients that have high level of potassium, there would be peaked T wave. So if we have the QRS complex, then we have a peak T wave there. In patients that are hypokalemic, on the other hand, you will have a flattened T wave. So again, if you have the QRS complex here, then there would be a flattened T wave there. And some patients may also present with U wave, which is another wave that follows the T wave. So here we have the T wave, and then we can have a U wave in patients that are hypokalemic. So again, hyperkalemia causes peak T wave, while hypokalemia causes the flattened T wave and U wave. And then ST segment elevation or depression can tell you about the status of myocardial infarction. So let's go over that next. So here we have an example of myocardial ischemia. Now you've heard of both the terms ST depression and ST elevation. What happens is that if the ischemia causes the subendocardial injury, the waves would be directed towards the heart, and thus there would be ST wave depression. On the other hand, if the injury is more severe and causes the infarction of the entire thickness of the wall, it's called a transmural injury, and the direction of the charges is away from the heart. So on V5, you will see actually a ST elevation instead of depression. So here I have an example of an EKG for you, which shows the ST segment elevation. So here we have the QRS, and then ST segment is elevated. So normally ST segment should come down here, and then we have the T wave, but it's elevated in this patient. And then there are labs that you can use to confirm myocardial infarction. These include the creatine kinase MB, as well as the troponin. So once the cardiac muscles are damaged, these proteins will be released, and thus there would be elevated levels of these proteins inside the blood. So with creatine kinase MB, it remains elevated for about 2 to 3 days, while troponin remains elevated for about 5 to 14 days. So it's possible to miss the CK-MB, while the troponin is less likely to be missed, and thus troponin is more reliable. However, if you have a patient that has been having, for instance, a myocardial infarction for 7 days, and then his condition starts to deteriorate, you suspect that maybe there is another myocardial infarction going on, you cannot use troponin as an indicator in this patient anymore, because the levels can remain elevated up to 14 days. With CK-MB, on the other hand, the levels by day 7 should have been gone down, and so you can remeasure these values and see if they were elevated. Then you can suspect that this patient had another episode of myocardial infarction. Now, the treatments that you can use in patients that are developing myocardial infarction include the B-MONA. So B stands for beta blockers, M for morphine to help with the chest pain, O for oxygen to help deliver more oxygen to the heart, N for nitrates. So it causes dilation of the vessels, particularly the veins, and so less blood will go to the heart, and it would lessen the work of the heart. And then finally aspirin. And then you can also give heparin. And then if the onset of the symptoms is within 12 hours, you can give thrombolytics to help break down the blood clot. And then you can also give these patients statins and ACE inhibitors to reduce the mortality. So in patients with myocardial infarctions, there are changes that you will see after the injury, and so you would need to know what microscopic changes and complications can arise in the time frame shown here. So in less than 4 hours, there's usually no microscopic changes, but the complications that may arise during this time include arrhythmia, congestive heart failure, as well as a cardiogenic shock. In between 4 to 24 hours, there would be a coagulative necrosis, and then there would be increased risk of arrhythmia. In 1 to 3 days, neutrophils will accumulate and cause inflammation, as a result of which there would be pericarditis in these patients. So they present with a chest pain that improves by leaning forward, and that should give you suggestions to the diagnosis of pericarditis. Between days 4 to 7, macrophages show up, And what they'll do is that they would destroy the cellular structures, and thus they can cause the free wall rupture, as a consequence of which these patients can present with the tamponade. It can also cause the papillary muscle rupture, as a consequence of which they would develop mitral insufficiency. There could be a ventricular aneurysm. And then finally, the interventricular septum can be ruptured, and thus there would be shunting of blood from the left to the right side. And then finally, weeks to months after the injury, there would be granulation tissue as well as fibrosis. And so there would be increased risk of ventricular aneurysm in these patients that increases the risk of emboli formation. In addition, because of the immunologic reaction, these patients can develop Dressler syndrome. So here we can have Dressler's syndrome, which causes inflammation of the pericardium. So they have similar symptoms to the pericarditis. Alright, now next I would like to discuss a few other EKG abnormalities. So with the atrial flutter, it has a sawtooth presentation. So here you can see it's like a sawtooth presentation. And then these patients have similar symptoms to those that have atrial fibrillation, which includes, for instance, palpitations, lightheadedness, as well as the shortness of breath. And then the treatment for patients with atrial flutter is the same as atrial fibrillation. You can use, again, the same thing, A, B, C, D, beta blockers, calcium channel blockers, or digoxin to control the rate. And then you can use the same anticoagulations like aspirin or warfarin in patients with atrial flutter. In patients with ventricular fibrillation, it could be fatal, and thus you will have to do emergent CPR as well as the defibrillation. Next, we have torsades, and torsades, what it means is that its translation means twisting. So this is actually a form of polymorphic VTAC, which can be either from the acquired causes, or it could be from a congenital condition associated with QT interval prolongation. Now, the reason the name torsades is given to this condition is that the waveform QRS that are shown right here, they are twisting around the isoelectric line. So if we have the isoelectric line here, you can see that they're twisting around it. And then same on this side. So that's why it's given the name torsades. And then the causes, the acquired causes include like medications, the two common causes of which are quinidine and sotalol. So actually, in about 1.5% of patients taking quinidine, they can develop torsades, and in about 2 to 4% of patients that are taking sotalol. So these two drugs are commonly associated with torsades. And the mnemonic that you can use is that sultan and queen are twisted together. So sultan goes for the sotalol, and then queen goes for quinidine, and then twisted together, twist goes for torsades that we have right here. Other medications that can cause the torsade include the macrolides, because they can also cause the QT interval prolongation, and non-sedating antihistamines like terfenadine can also cause that. And then electrolyte abnormalities such as hypokalemia as well as the hypomagnesia can cause the torsades as well. And then the treatment for patients that develop torsade is magnesium. So just keep that in mind. If you see that wave on the exam and then they ask you how can you treat this patient, then you will have to give them magnesium. Now, as for the congenital condition, there is a syndrome called the Jervell-Lange-Nielsen syndrome. So these patients have the QT interval prolongation because of defects in the cardiac magnesium or potassium channels. In addition, they can present with the congenital sensory neuronal deafness as well. So just keep that in mind, that this syndrome is associated with torsades because of the QT interval prolongation from defects in the cardiac magnesium or potassium channels, and then they could also present with the sensory neuronal deafness. Next, we have the first, second, and third degree heart blocks, and then we'll be done.
And so what happens with the atrioventricular heart block is that there is interruption of impulse transmission from the atria to the ventricles, which could manifest as some sort of a conduction delay in the AV node or a complete AV block, as a consequence of which you will notice that the atria depolarization and ventricle depolarization have some sort of dissociation.
So for the first degree heart block, all you have to know is that the PR interval is more than 0.2 seconds. So you may recall that I mentioned that the PR interval should be between 0.12 to 0.2 second. If it goes beyond 0.2 second, then that's the first degree heart block. So here you can see, if we had one small box correspond to 0.04, then the entire 5 blocks correspond to 0.2 seconds, and then 3 of them correspond to 0.12. So here you can see that the PR interval is more than 5 small boxes that we have here. So this is an example of the first degree heart block. Next we have the second degree heart block. A second degree heart block divides into 2 types, Mobitz 1 and Mobitz 2. So with Mobitz 1, the PR interval keeps on increasing in duration. So here we have this size, then it keeps on getting longer, until there is a dropped beat, and then it will repeat the cycle again. It keeps on getting longer until there is a dropped beat. With Mobitz 2, on the other hand, PR interval does not change, but there are occasional dropped beats. So here you can see that we have 2 P waves before we have a QRS. Then we have another 2 P waves before we have QRS, another 2 P waves before we have QRS. And in patients with Mobitz 2, you will have to treat them with a pacemaker. And then finally we have the third degree heart block, or the other name for it is a complete heart block. And since there is a complete heart block, the P wave and the QRS are completely independent of each other. So here you can see that the QRS are beating by their own, no relation to the P wave, while P wave are just going by themselves too. So they have regular rhythm of the P waves and regular rhythm of QRS, but no relation relative to each other. And then again, just like Mobitz 2, the treatment in patients with the third degree heart block is a permanent pacemaker placement. Now, I didn't mention earlier that patients with left bundle branch block, if they are asymptomatic and they have an isolated episode, then you can leave them alone. However, if they become symptomatic and they progress into Mobitz 2 or third degree heart block, you will have to treat them again with the permanent pacemaker. And then you would use the same approach in patients with the right bundle branch block. If they're asymptomatic, you just leave it alone. If they develop into the Mobitz 2 or third degree heart block, then you can treat it with the permanent pacemaker.
Alright, next I would like to discuss pericarditis, which we have briefly touched upon earlier in the lecture. So pericardium is a fibroelastic sac that surrounds the heart and helps it function properly. With pericarditis, which refers to the inflammation of pericardium, these patients present with chest pain. And once you listen to their heart with the stethoscope, you hear kind of like a superficial scratchy sound known as pericardial friction rub. And then their EKG is characteristic of diffuse ST elevation in all leads except for sometimes not in V1. And with the AVR, you will see reciprocal ST depression. So with pericarditis, you get diffuse ST elevation in all leads. So here, if you pick any leads, you see that there is ST elevation in all of them, except for sometimes not seen in V1. And with the AVR lead, you will see ST depression. Now let me ask you, what's the difference in the presentation of EKG for pericarditis versus STEMI? So first, could you tell me what STEMI stands for? STEMI stands for ST segment elevation in myocardial infarction. So those patients that have a heart attack, they can have ST elevation in certain leads. And unlike pericarditis, where there would be diffuse ST elevation and reciprocal ST depression in AVR node, with the STEMI, you will see ST elevation in certain leads depending on where the blockage of the vessel has happened and where is the myocardial infarction, which part of the heart is being affected. So you will get ST elevation in certain leads. And we will discuss STEMI in more detail in our next lecture. Next, I would like to discuss supraventricular tachycardia. So as the name implies, supraventricular means above the ventricle. So the source of depolarization of the ventricle is above the ventricle. An example of which includes, for instance, Wolff-Parkinson-White syndrome, where due to the bundle of Kent, there would be depolarization of the atrium bypassing of the AV node and causing the depolarization of the ventricle. So the source of depolarization of the ventricle in these patients is above the ventricle, presenting with a fast heart rate. And one important feature in these patients is that QRS interval is less than 80 milliseconds. So the QRS interval is pretty narrow, less than 80 milliseconds. Versus if we look at ventricular tachycardia, where the source of the contraction is the abnormal depolarization of the ventricle presenting with a fast heart rate, these patients have wide QRS interval of more than 100 milliseconds. Okay, you can see here that these patients have a wide QRS interval. Now with the sustained ventricular tachycardia of 30 seconds or more, because the ventricle is beating so rapidly, the heart cannot pump well the blood to the different part of the body, as a consequence of which patient can undergo hemodynamic collapse. And so for these patients, you have to proceed with the ACLS resuscitation protocol as well as CPR. Okay, so let me summarize all the findings. With the sinus tachycardia, we will have normal depolarization. These patients will have QRS interval of 90 to 100 milliseconds. As an example of the sinus tachycardia is like, for instance, once we are working out and exercising, our heartbeat can go above 100, and that is referred to as sinus tachycardia. With supraventricular tachycardia, the source of depolarization is supraventricular, above the ventricle, like for instance in the atrium in Wolff-Parkinson-White syndrome. And a characteristic feature of the QRS in these patients is that it's narrow and less than 80 milliseconds. And lastly, we have ventricular tachycardia. Okay, could you tell me, where is the source of depolarization? The ventricle. And how wide or narrow is the QRS? It's pretty wide, more than 100 milliseconds. And what happens if it's sustained 30 seconds or more? Patients will undergo hemodynamic collapse, and you got to do ACLS algorithm and the CPR for these patients. Okay, so that was the summary of these. And then moving on with the last two conditions, which is pretty straightforward. As the name implies, premature atrial contraction is because of the premature depolarization of the atrium, where there would be an extra heartbeat. So here you can see that we have a normal heartbeat in this patient, regular. So if we go by the boxes here, 1, 2, 3, about 4 boxes apart is each heartbeat. So 300 divided by 4 is equal 75 beats per minute. Normal heartbeat is 60 to 100. So this patient has a normal heartbeat, it's regular, but we see that here we have an extra heartbeat. And this is an example of premature atrial contraction. This is the most common sinus arrhythmia in children, and that they might describe it as their heart flip-flopping. And as a matter of fact, this is a benign condition, not to worry about it. And then the final one is the premature ventricular contraction, where due to the premature depolarization of the ventricle, there would be an extra heartbeat. This condition can also happen in normal individual, and it's not dangerous, not to worry about it. Patients might describe it as their heart fluttering or having a skipped heartbeat. However, if we have this condition in some patients with cardiac anomaly, then that could be more dangerous. All right, now that we are done with the discussion of these different EKG findings, next I would like to quickly review all of these. So if you're making any notes, you want to put them aside. The next few minutes is just purely review, and you could continue going over it and listening to this section over and over until you feel comfortable with all the findings. So let me clear the board again. All right, first condition. What kind of EKG anomaly do we see here? So you can see that there is an ST segment elevation in these patients. And what conditions can present with the ST segment elevation? We discussed it could be STEMI, where there would be a ST segment elevation in certain leads depending on the location of myocardial infarction, or we can see that, for instance, in pericarditis. And where would be the ST segment elevation in these patients? It would be diffuse ST segment elevation in all leads, except for sometimes not seen in V1. And then how about the AVR? We see the reciprocal ST depression in AVR. And that is an example of pericarditis. Okay, next, what kind of anomaly do we see here? Here's an example of a delta wave seen in Wolff-Parkinson-White syndrome, where the atrial depolarization can bypass the AV node via the bundle of Kent. And so this is a condition that can cause supraventricular tachycardia because the source of the ventricular depolarization is above the ventricle in the atrium. Next, we have the bundle branch blockers. So let me show you in this image how the bundle branch block works. So here we have the right bundle branch, and on the left side we have the left bundle branch. So in this example, there is a right bundle branch block, as a consequence of which the depolarization will first start in the left ventricle, but not the right ventricle. Now, left ventricle myocytes also have their own electric signal. So eventually the electric signal will bypass the septum and transfer to the right ventricle and causes depolarization of the right ventricle. But there would be a delay because there is now blockage of the right bundle branch. Same happens with the left bundle branch block. If there is a left bundle branch block, the left ventricle will not contract, only the right ventricle will contract because of the depolarization. Once the right ventricle contracts and depolarizes, electric signal will bypass the septum and causes then the depolarization of the left ventricle. Alright, and then looking here is quite straightforward if you use these two memory aids, William, Marrow. So for the William, L is for the left bundle branch block, and for Marrow, R is for right bundle branch block. So you look at the V1 and V6 leads. For left bundle branch block, in V1 you will see W, while in V6 you will see an M pattern QRS. Versus for right bundle branch block, in V1, so these are V1, the next one is V6. So for V1 you will see M pattern, while for V6 you will see a W pattern. Okay, now of all the ones listed here, left bundle branch versus right bundle branch, could you tell me which one is a more serious condition? So the way to remember it is right bundle branch should make you think of a rabbit ears, and so rabbit ears are harmless. So right bundle branch block can be seen in normal young healthy individuals, versus left bundle branch block is almost always associated with some sort of a heart disease. Next, EKG. You can see that the rhythm keeps changing in these patients. So this is an example of an irregular heartbeat, which is seen in what condition? Atrial fibrillation. And if you pay attention, you can't see a distinct, obvious P wave in these patients. So there is an absence of distinct P wave. Okay, so absent of a distinct P wave. And what are the clinical presentations of patients with atrial fibrillation? That would be these patients will have palpitations, tachycardia, lightheadedness, and decreased exercise tolerance. Next, what kind of pattern do you see in this EKG? This is an example of a sawtooth. Okay, so there is an abnormal cardiac rhythm of sawtooth appearance where there is a rapid regular atrial depolarization of more than 300 beats per minute. And similar to atrial fibrillation, so this is atrial flutter. And similar to the earlier one, which was atrial fibrillation, these patients present with palpitations, tachycardia, lightheadedness, and so on. All right, what do we have here? So remember, with the EKG interpretation, you can start with the rate, rhythm, and so on. So what's the rate in this patient? Let's use the rule of 300. There is about between 2 to 3 boxes away is the heartbeat here. So meaning that this patient's heart rate is between 100 to 150. If you want to be more accurate, it's somewhere in between the box. So I would say about 125 beats per minute. So what is a normal heartbeat? How many beats per minute is normal? 60 to 100. Less than 60 is considered bradycardia. More than 100 is considered tachycardia. So this is an example of a sinus tachycardia in this patient. Next, what do we have here? So here you can see that we have rapid disorganized depolarization of the ventricle. And so this is an example of a ventricular fibrillation. Okay, and these patients can present with a sudden collapse because the heart cannot pump blood properly. What do we have next here? So if you compare this one to the earlier one that we have here, you can see that there is rapid heart rate, but the QRS interval here is 100 milliseconds versus in here, what's the QRS interval? It's very narrow, less than 80 milliseconds. So this is an example of a supraventricular tachycardia. How about the example shown here? So again, there's a rapid heartbeat, but the QRS interval is pretty wide. It's more than 100 milliseconds. So this is an example of a ventricular tachycardia. And what happens if this condition lasts 30 seconds or more? So with sustained ventricular tachycardia, patients can collapse, okay? And then you have to start CPR and the ACLS resuscitation algorithm. All right, next, what do we have here? So like I said, first we start with the rate, rhythm, and so on. What's the rate in this patient? So how many boxes away? So we can see 1, 2, 3, about 4 boxes is each heart rate away. So 300 divided by 4 is equal 75 beats per minute. Normal is 60 to 100. So this patient has a normal heart rate. All the P waves are followed by a QRS, okay? But here we can see that one anomaly that we see is that there is an extra heartbeat. So this is an example of a premature atrial contraction. Is this condition dangerous or not? No. Premature atrial contraction is benign, and as a matter of fact, this is the most common sinus arrhythmia that is seen in children. Next, we have premature ventricular contraction, okay? And this condition, again, is it benign or not? So if a patient has some sort of cardiac defect, it could be dangerous, but PVC is seen in normal, healthy individuals, and it could present as a fluttering or a skipped heartbeat. What do we have next? So here you can see that the QRS is twisting around an isoelectric line. So this is an example of a torsade. Next few, we'll go over different heart blocks. So what do we have here? What is happening to the PR interval? It's the same. It is not changing, and every PR interval, every P wave is followed by a QRS. So this is an example of a first degree heart block. And just be careful, some of these might not be in order, so just pay attention. So how about here? What kind of heart block do we have here? What is happening to the PR interval? So here you can see that the PR interval is getting longer, longer, longer. Eventually there is a missed heartbeat. Okay, so this is an example of a Mobitz 1. What do we have here? So you can see that we have the P waves here. And then we have the QRS. Okay, so the atrial depolarization and ventricular depolarization, they're completely independent of each other. Here you can see that the ventricles are depolarizing regularly at their own pace versus atria are doing it regularly at their own pace. So once atria and ventricular are depolarizing independent of each other, this is an example of a third degree heart block. And then the last example we have here, you can see that we have the P waves, and then we have the QRS. So you can see that here the PR interval is not changing, but not after every P wave we get a depolarization. Okay, so this is an example of a Mobitz 2 heart block. So here in this example, after every 2 P wave we get 1 QRS. 2 P wave, 1 QRS. Alright, so that would conclude our discussion of this video. We have one more video, and like we discussed, that one will be focusing more on the coronary artery disease and congestive heart failure. And for those of you that might not be aware, we also have a note-taking booklet on Amazon that could help you take notes while listening to this video. Once again, thank you all for listening, and see you for the next lecture.